The primary topic of conversation, the thing we're going to spend the rest of our time on, is vertigo, because this is probably the most common primary care phenomenon that produces this sense of dizziness. And like I said, peripheral vertigo is something that we manage in the primary care setting. It doesn't really require a referral. So we do want to spend more time talking about that. Vertigo, like I said, is there is a sense of spinning. Now, if you are like a vertigo expert or an ENT expert, you would break this down into primary vertigo, where the patient, him or herself, feels as if that person is spinning, or secondary vertigo, where they feel like the room is spinning. I'm not a specialist and I'm not that fancy. So once I deduce that there is spinning going on, that's all I need to know that I'm managing vertigo. Like I said, in the specialty settings, they get the people that don't respond to traditional interventions. They don't have the common causes. So if you evaluate vertigo, you deduce that it's peripheral vertigo and you treat it appropriately, and the patient still doesn't improve, that's when you consider a referral to ENT. And that's when distinctions like primary or secondary vertigo become important, because there's obviously some odd underlying thing going on. But for you and me, it is fine to just deduce that something is spinning. This too, vertigo is also often accompanied by other symptoms, and this is an important part of our workup early on, is to assess what those other symptoms are. Vertigo can occur in any position. There is no rest for the weary, right? No relief from this. If they're standing up and it happens and they sit down, it's still happening. Sometimes people wake up and it's happening, or they open their eyes in bed, they sit up and it's happening. Vertigo can occur in any position. It is the cardinal symptom of vestibular disease. Just statistically, it is more often an inner ear problem than anything else. It certainly can be other things, but it is the cardinal feature of vestibular disease. In other words, if somebody has a vestibular problem or an inner ear problem, they will almost always have vertigo as a presenting symptom. Another thing about vertigo is that it is virtually always exacerbated by head movement, and it is never continuous. The patient gets breaks from it. Sometimes vertigo just lasts for a matter of seconds. I know I'm saying just a matter of seconds. If you're living it, it seems like forever. But vertigo is either a matter of seconds, or in some circumstances, it can be a matter of minutes, which it's like feels like years to the patient. But it's not like all day. They definitely do get breaks from it. It is never continuous, and acute vertigo is virtually always exacerbated by a turn of the head. So this is why people, when they're telling you about it, they'll turn their head when they're talking. If they happen to turn their head, then they're like, oh God, I shouldn't have done that, because that head movement always makes it worse. Those are real cardinal features of vertigo.